Patient and public involvement in palliative care research is increasingly becoming recognised as a valuable means to improving the quality and the relevance of palliative care research. It's starting to become recognised as a central means to also achieve better outcomes for patients and families. It's a privilege today to be presenting, or co-presenting rather, with Kirstie Newson, who's one of our service user advocates here in the department. And Kirstie's been instrumental in shaping some of the public and patient involvement work here in the department. Kirstie works collaboratively with a number of our strategy executive committees here in the department, and also collaboratively with a number of researchers here, including Sue DeWolf-Linder, who's a quality improvement facilitator who's helped with this work, Jana Witt, a research associate and project manager, and Carolyn Morris, who unfortunately couldn't be here today. She's another service user advocate who's helped develop this work. So I'm going to hand over first to Kirstie, who's going to help set the scene for this presentation. She's going to explain some of the reasons why collaboration between researchers and service users is so important, and also explain or share some of the results of this type of work.
I'm going to start off with a very personal perspective. 17th of March 2010. Mum was increasingly agitated and in pain. She would repeatedly plead, "Let me go," but we had no means of helping her. After what seemed an eternity, the nurse finally arrived. Once she had spoken to me, she asked Mum if she could give her some medicine to help her feel better. Mum replied, "Ask Kirstie." I was hit by a wave of emotion at this. The fact that she was lucid enough to say that meant that she still recognised my role, but horrendously must be aware of what was going on and therefore how much she was suffering. It had been torment for us to see, so what must it have been like to experience it? They were the last words she said. That excerpt was taken from my diary of the time I cared for my mum when she died at home. I was my mum's carer throughout every aspect of her treatment. At hospital, I knew what questions to ask, knew she'd been referred to the wrong team when her cancer returned, and didn't wait for the system to sort it out, but did so myself, hoping that the time saved would make a difference. I don't like battle metaphors, but I really was fighting for my mum's survival. However, the palliative care world was different. When the hospital sent my mum home to die, and whilst Mum already had a hospice nurse, I felt totally alone. But like my mum, I'm one of life's copers, so of course I came across as in control. Mum needed me to be. All the way through the pathway, with very evident relief, every doctor or nurse I met acknowledged how well I was coping. And I was, in some ways. But by this stage, I did not know what I needed to know. Coping wasn't enough. And inside, I was screaming. On paper, it could be said that as my mum's wish to die at home was respected, it was a good death. But I don't think that the way in which she died was good enough. I somehow knew that then, but with the benefit of time, I am able to see more clearly how things could and should have been better. And my mum wouldn't have had to suffer like she did. My views on what could be improved is not the purpose of this presentation, but this is just to serve as a reminder that, like many other people, I have a perspective that could be helpful. I think it is worth remembering that you only die once, but whilst for others, that death can leave a legacy that goes on for your loved ones. What kind of death do you want? What kind of legacy do you want to leave those you love? And this is why I'm involved with the Cicely Saunders Institute. I want to make a difference to the care that others receive at the end of their lives, but also their loved ones. When you or someone you love is dying, those palliative care services should be responsive to need. How can they truly do that without being informed by strong research? How do you ensure that that research is the best? How can you as researchers know every aspect there is to know? Unless you talk to people with personal experience, how do you know what wisdom you're missing? Listening to people like me and many others not here today, we can tell you what it's like. We can talk about the questions we wish we had asked, make suggestions about what might make a difference. But we can also reinforce what works so that those elements are not lost. And by working with people who are currently experiencing palliative care, you may help them shape their own legacy for the better. As one of my fellow service user representatives with a life-limiting condition said only the other week, my involvement in research turned a very negative experience into a positive. So for me, the question is really, how can you not work with people who experience these services and know them best, and still hope to be a good researcher?
So Kirstie's highlighted that when we talk about involvement in palliative care research, patient and public involvement, or PPI, we're talking about working with people, doing research together collaboratively, not research to, not for or about people, but collaboratively with them, deliberating, considering, integrating people's suggestions to improve the quality and relevance of the research. And this can happen at all different stages in the research project. It can happen at one stage in the ideas generation part, or right throughout the whole process. And here in the UK, a number of service users now sit on commissioning boards to fund research and to evaluate research. So it's helping to change the culture within research communities. And when we use the term consumers, well, who are we referring to? We're referring to patients, potential patients, unpaid caregivers, people like me, people like some of you in the audience, people who feel that they may have been harmed by accessing certain services or trying to access services but yet can't access them because of some reason. People who have established service user panels both at a regional level, like the European Cancer Patient Coalition, which we work with here in the Cicely Saunders Institute, which works with a number of umbrella organisations across the EU, and local organisations like the South East London Consumer Panel. And there are a number of different reasons why this work is so important. There's the ethical imperative. Surely it's morally the right thing to do, isn't it? To work with people, to include people, to allow people to exercise autonomy, to allow them to exercise agency related to self-determination. Everyone has the right to information, and through involving people, we can give people access to very privileged knowledge and privileged information. The health economists in the room might disagree, but it seems to be two camps in relation to the health economics of involving people in this sort of work. One is that it saves researchers money because you can hand over some of the tasks that are involved, and the other camp says actually it costs more money. People should be reimbursed to acknowledge some of the contribution. They shouldn't be out of pocket. So it actually makes it more costly, but it improves the quality. Either way, a number of researchers that do engage in this sort of work do say that it improves our awareness of the costs that are involved in research and makes us consider where we need to delegate and where we need to share some of the tasks. There's also the theory in healthcare, when you involve people to shape services, that people that are more informed and more engaged will look after themselves in a better way, and we can apply that rationale to involving people in research collaborations. The WHO says that healthcare systems and services should be built on people's preferences. They should be responsive to what people want and to what citizens tell them is important. And through involving people in research, we can help set up some of these systems and services and be responsive in that way. And of course, there's a social justice imperative as well. Oppressed people find it difficult to access certain sectors of healthcare or certain types of services. And through involving people that experience oppression in society, we can build up these services and in so doing, increase equity and increase access. And I like this little poster on the side here. It's not really a cartoon, it's more a poster. And it sort of shows us that all of these factors are inconsequential really, unless there's a mutual benefit that occurs throughout this collaborative process. Unless I benefit and Kirstie benefits and the organisations benefit and the systems benefit, especially in the Cicely Saunders Institute. And we do that by having open and honest discussions at the early phases of the research process to ask people what are their expectations of being involved, what do you want to achieve through this, and also being very open about what we would like to work with them on and what we hope to achieve through this process. With a growing interest, there are a number of different frameworks that have been developed to help us understand service user involvement. And right down the bottom here, you have more tokenistic approaches. So, for example, consumers are sometimes placed on advisory boards, but yet they have no power to make decisions. And then right up the top, you have more citizen-led work and citizen-informed work, which help really to make some of the decisions, and the researchers are led by them. I like this framework because it's a nice way to help me reflect upon my own experiences and my own tendencies to my research practice. And when I first began, I really started more at this consultative level. An example of that is that we developed some lay summaries from some of the research that we did, and we took it back to the lay groups and we said, give us your opinion on this, what do you think about it? And then we integrated some of their feedback into how we interpreted some of the research and disseminated some of the research. But now I'm moving more solidly up into this joint collaborative process. An example will also show of some of that work here today.
If I just touch on how I've been involved, obviously I've been involved with the Cicely Saunders Institute now for a few years. I started off actually by trying and rightly failing to get involved in quality care. However, Barbara Gomez was great and she kept me informed, and before I knew it I was asked to be a co-applicant on a couple of unsuccessful funding bids. And along the way I was being consulted about various papers or press releases. And most recently the sort of the consultation stage has been around the Research Excellence Framework submission. But the most significant involvement really has come through the BuildCARE programme, of which why we're here today. And both Carolyn Morrison and I were asked to be part of the advisory group for the dissemination, engagement and empowerment workstream, which really acts as the interface between the other work streams and the audience we're trying to reach. And where appropriate and possible, Carolyn and I try and do more than just sit on the advisory group. We do try and get involved. So Carolyn's chaired a seminar before now. I've responded to the speaker, speaking at conference presentations. And we do as much as we can to help get the message out there. So really, it's just an example of how the Institute has sort of supported a sort of the higher up the hierarchy involvement approach.
And that framework's been developed further to inform some of the work done by Involve here in the UK. That's linked with the National Institute for Health Research, and they've developed that to outline 3 different types of or degrees of involvement in research, ranging from consultation through to consumer-led research. So the evidence has also grown to support involvement work in palliative care research, and there was a recent Cochrane publication published in 2013, and it looked to include all RCTs that had assessed the effects of consumer involvement and the different methods of consumer involvement in relation to the development of healthcare policy, healthcare research, clinical practice guidelines and patient information material. And they found the most evidence in relation to consumer involvement to develop patient information material, and that was related to material to do with patient-controlled analgesia and endoscopies. So they found that the material that was created was more relevant, it was more readable, more understandable. It didn't invoke any more anxiety in the patients that were engaging with this subject matter, and they reported that it improved their knowledge. And this ethnography that was published in The Lancet is quite interesting too, because it shows some of the differences between healthcare professionals' relationship with service user involvement as compared to patients. And in the findings, what we found here is that the healthcare professionals spoke about involvement in a real linear way. So they said, you know, we would do this, it would lead to that, then this would happen. They said it made their work much more complex, and they said they wanted more evidence so that they could fully engage in this work. In contrast, the service users said, you know, I view this work in a much more collective way, and how I evaluate this success is related to whether or not there's a rapid implementation of some of the changes that I'm suggesting and whether or not that improves the services. And they expressed some of this work in relation to the collaborative relationships which were established with the people that they were working with. So this study helped spark the idea for a workshop that we've done recently as part of BuildCARE here in the department. And what we wanted to do is to understand in a more sophisticated or a better way the preferences and priorities of service users, so patients, their families and members of the public, as compared to researchers when it comes to involvement in palliative care research.
I think through the work stream, the advisory group that we're part of, I think we build up quite a lot of trust working with the researchers and other members of the group. And we really wanted to explore further. We recognised that whilst involvement was good, we could do it better, really. And we wanted to make sure that we had a more unified and evidence-based approach to what we were doing. So Barb, Jana, Suzanne, Carolyn and I started to think about how we could develop this. And we decided that we would be bringing together as many current users as possible and a small number of researchers, because we didn't want them to dominate, but we still felt their voice was important. And we brought them together into a workshop with the aim of developing a model of involvement for the CSI to improve the quality and relevance of the research. And what we decided to do was build an approach, I think, that was used in more care research. So using the nominal group technique to structure the process of generating the content and helping identify the priorities within the workshop. And there were 4 of us that facilitated that workshop. It was Caroline, Jana, Suzanne and I. And we had some key questions that really provided the structure for that workshop and formed the basis of each section. And I don't know if you know about the nominal group technique, but I'll just briefly run you through it. Initially, participants were asked to individually list their own ideas about the questions put up here on the paper. And then in small groups, we shared the most important idea to each person in turn and developed a composite list for each question. And then collectively, we shared those composite lists back to the whole group and allowed plenty of time, the most amount of time of the workshop, for discussion and evaluation of those ideas. And then individually again, we asked all participants to rank the ideas, because they sort of got merged together in some of that discussion. So we asked participants to rank the ideas on paper, and we collated that list back in. But because we wanted everyone in the workshop to go away with a sense of where we were going, we also asked everyone to do a quick show of hands of their top 3 sort of items on the list, so everyone could have a sense of the overall results before they leave. Now, this workshop was only a couple of weeks ago, and the results are still literally just being collated, so I'll get Barb to talk you through those now.
Okay, so this is the information from the service users and the researchers. We didn't include the priorities from the end-of-life care commissioner or the person who was involved in facilitating R&D processes, even though we could have collated that with the service users' perspectives because they're part of the public. So the first question was really about how can consumer involvement improve quality and relevance of research? And what the service users very clearly said here was that it could widen the access of palliative care research to the public. It could help us go beyond the cancer model and include people with other conditions and illnesses. This needed to happen at every stage of the research process though, right from the idea generation phase to the writing the proposals to the dissemination and then to the developing of the new ideas to be embedded into the next proposal. Interestingly, the researchers put more weight on the idea generation phase, and they were saying it's really important to collaborate with service users at the beginning before we have our ideas and we start to run with those ideas. The researchers highlighted that it could help improve the quality and relevance through helping to identify our biases that we bring to the development of research proposals and to ensure higher quality. The second question was about how do we do it really? What's the best model? Both the service users and the researchers said very clearly a flexible model is required. We need something where people can pick and mix, can dip in and out of. We need flexible ways of engaging people, different levels and types of engagement, and we need to get to diverse groups of people. Interestingly, the service users also said it will work best when you make it visible, when you celebrate our contribution and that you show its value, and that you allow the impact of what we do to be celebrated and showcased. The researchers said it would work best also if we could tap into the service users' abilities to go and help widen our net to include other service users in this involvement process. And it needed to be well planned, and importantly, it needed to be properly funded. So the final question was about how can everyone benefit from this sort of work? And the service users said, well, we can all benefit from it because we can go and sell your message. We can go and tell people, we can get patients and families and the public to understand why this work is so important. Researchers focused on how the patients, families and public could benefit from it. They said, we can help empower people and we can recognise and value the contribution that people make to this process. Both said, this sort of work can help demystify palliative care. It can help raise awareness of palliative care services and also raise awareness of research. And the researchers also said that it's an important process to help reduce wastage. So the main messages from the service users was that involvement can aid in improving reach, public engagement and impact. Whereas for the researchers, there was more an emphasis on quality as well, improving accountability, improving governance structures, but also there are the benefits related to public reach and engagement. So we put these two perspectives together and we came up with an overall synthesised result, which is a flexible model of patient and public involvement in palliative care research has the potential to result in improved quality, efficiency, reach, impact and engagement. It also may result in a secondary gain of increased understanding of palliative care, improved public engagement with wider and more diverse involvement, and ultimately this can help improve the research quality and relevance.
The emerging recommendations, I think, coming from this research is really we need to think about different platforms for involvement, and we very much talked about virtual networks and supporting that through electronic communication, social media, but actually at the core having more of a partnership group that perhaps is more involved in the decision-making process. But within that range, you still want that pick and mix and flexibility. We really want to push and encourage that involvement should happen at all stages of research, and one of the workshop participants talked about speed dating as a way of bringing users and researchers together. You could see that as an end to itself, but actually I see that as a starting point. That's the place where you could germinate ideas and develop potential partnerships, and so that can go on and take the research from that inception point right through to completion. And then I feel this one is very much a plea from the researchers really around the service users and public helping diversify involvement. I absolutely recognise we need to do that. I think there is a little bit of a challenge around how, and that requires more thought, but we do have networks, we should be using them. And as Barb pointed out earlier, all of us are sort of consumers of healthcare in some way, shape or form, and we should think about what we can do to take back to our own families, friends, networks, whatever we have. So I think there is a challenge around that, but I think it's still important to recognise. I think actually something that hadn't crossed my mind before the workshop was around the guidance for researchers. I kind of made an assumption you didn't know all this, but actually, they're asking us to help them. So, do we think about mentoring researchers? Do we think about developing masterclasses or written guidance? And then the final thing, which I think the Institute does quite well already, but there's obviously room for improvement, is around optimising that dissemination by people like myself. That is through those networks if we have them, but also it is about co-presenting, like we are today, and co-authoring. And it's been very clear when I've been working, or Carolyn and I, have been working with Barb, Jana and Suzanne, that every step of the way we have co-developed this. They are clear that it's a joint process. They never, they're talking about writing it up for a conference presentation later in the year, and they want us to be co-authors. It's never a them and us, it is a collective, collaborative effort. The challenge for us is how much time we can give to that, but that's, I think we more or less get that right. So really there are recommendations, and we just want to really end on a quote really. No matter how complicated the research or how brilliant the researcher, patients and the public always offer unique, invaluable insights. Their advice when designing, implementing and evaluating research invariably makes studies more effective, more credible, and often more cost-effective. And this quote comes from Sally Davis, and she has always taken the view that public involvement in research should be the rule, not the exception. Thank you.
Thank you.